Thank you very, very much for that
Thank you.
kind introduction. It's delightful to be back. Well, obviously not really back, but as back as you can be nowadays. But it's really also delightful to see so many familiar faces on the Zoom screen. And for those with their cameras switched on anyway, and for those with their cameras switched off, it's lovely to see so many familiar names in white on black screens as well. It's delightful in lots of ways. Malcolm did a very sensible thing in getting his thank yous in first, and I'd like to do the same thing. I'm going to be presenting you some data today from the SIMBAD study, which is a large randomized controlled trial, which we ran from Sussex, from Brighton Sussex Medical School, that we recruited to in Sussex Partnership Trust and surrounding trusts as well. Sussex was the second highest recruitment site. We just got pipped at the post by Newcastle, but without the fantastic work of people all through Sussex Partnership Trust, all through Brighton and Sussex Medical School and the University of Sussex and the University of Brighton in supporting us, and also vitally with the patients and carers that supported us in developing the project, in monitoring the project all the way through and delivering that project. Without that support, we really wouldn't have been able to present the data that I'm going to present to you in a minute. So thank you for all of that. On to the talk. Now, this is where I get to share my screen and see whether it works or not. So somebody, perhaps Malcolm, will have to tell me whether or not my screen sharing attempts are actually working. So
it's looking good so far.
It's looking good so far. Okay, so
Sube Banerjee has started screen sharing, but we haven't seen the pictures yet. I'll tell you when we do. There we are. That's looking great.
Okay, brilliant. So hopefully you can hear me and hopefully you can see this. So I'm going to talk about agitation in dementia, and I'm going to talk something about therapeutic options and try and put it in context about the nature of the challenge that we have, and also what we might do practically about this, profoundly difficult thing for people with dementia and for those that care for them. And as I said, I'm going to introduce some data, some new data that we published last year in the Lancet, and some other data that we have yet to publish also. So if we start off looking at dementia, there are bits of dementia that are more popular than other bits of dementia. It's like it's a cocktail party, and there are people that people want to speak to, and there are people that kind of sit in the corner and nobody speaks to them. And the bits that people always talk about with dementia are cognitive impairment and functional limitation. They're seen as absolutely core to dementia, and there is a vast amount of work done on those. The things that are more Cinderella-ish are neuropsychiatric symptoms and things like social impairment. Now, that doesn't mean they're not important. In fact, there is very good data to suggest that neuropsychiatric symptoms and social impairment are much more important in terms of determining poor quality of life for people with dementia, or good quality of life if you can treat them. And that relates to the theme of this conference. So let's think about neuropsychiatric symptoms. What do we mean by those? Well, we mean a whole bucket of different possible things. And that's one of the themes that we're going to come back to, the fact that actually this isn't the same as a highly specific disease. This isn't the same as hairy cell leukemia or something that's a specific disorder with a particular etiology. What we have is things like agitation and depression and sleep disturbance and psychosis and apathy. And there are multiple ways to this. And neuropsychiatric symptoms are a bag of different symptoms which may well have very different etiologies. What we do know about them, though, is that they're common. About 90% of people with dementia at some point in their illness will have these, and they're often persistent. Now, agitation is one of the most important and difficult and complicated things. And again, common 50% of those people with dementia will have them at some point in their illness, and they're persistent as well, so that those that have them are likely to still have them. Half of those people will have them 1 month later. And you can divide aggression into verbal aggression, non-aggressive agitation, wandering around, and aggressive agitation, which can be physically dangerous for family members who are caring for those individuals and present, and all of these present tremendous challenges for the person with dementia, primarily in terms of decreasing their quality of life, but also for families looking after people, and for those people in hospital or in care homes, for those staff that are looking after them. And if we think of causes, things like unmet need, pain, hunger, thirst, constipation, delirium, and without wishing to jump to the end of the discussion, it's very difficult to see how an antipsychotic or any drug, for example, is the right treatment for pain, for hunger, thirst, constipation, or delirium. It can be a response to stimulus in those environments. It can be about the expression of psychosocial needs. It can be about the way that we approach people creating anxiety. And dementia, as a fundamental primary cause of agitation, I have put right at the bottom of this list, because you have to make sure that all of those things are ruled out before you assume that the behavior you're seeing is a function of the neurodegeneration that is going on in an individual with dementia's brains. And there's been an evolution of language that kind of reflects this, that reflects the fact that this is perhaps not a simple medical syndrome, but in fact a response to environment. The term that is still very widely used, behavioral and psychological symptoms in dementia, was coined by a drug company, which brought together a group of people to try and define a target for pharmacotherapy. And we've had challenging behavior, and the question then is, who is it challenging to? Is it challenging for the person with dementia, or those people caring for that person? And then the idea of responsive behavior, whereby you are challenged to think of what is causing it, rather than what drug you should treat it with. But we know that agitation's a bad thing. The consequences cause deteriorating relationships. It promotes care home admission, hospital admission, increased costs of care, carer burnout, carer burden, and decreased quality of life. And obviously there are associations with mortality also. And here's some data, and we've known for a long time, this is some data from a study that we carried out way back in 2006, that shows that if you look for what drives quality of life for people with dementia, it is those neuropsychiatric symptoms. It is irritability, disinhibition, anxiety, agitation, all of those things. So they are an absolutely legitimate area for people to seek help with, and a legitimate area for us to offer help for as well as clinicians. So if we look at what we should be doing with people with dementia who have agitation, here we have, I'll share some information from the Lancet Commission on Dementia Prevention, which again we in Sussex contributed to, looking at approaches to assessment and management. And you see that what they suggest is they're asking, is the agitation, what are the symptoms, are there treatable causes? Also thinking about risk, so you assess for causes, you assess for risk, you then treat those causes, whatever they might be. So, the treatment for pain is not an antipsychotic, the treatment for pain is analgesia and the removal of whatever is causing that pain. Only then, when you have done all of that non-drug work, do you even consider so you consider non-drug interventions, and then only at the end drug interventions. And non-drug treatment works. This is a systematic review from Jill Livingston and her team at UCL, just showing that there is ample evidence out there that almost whatever you do that isn't drugs does work to help agitation. So person-centered care, communication skills, that's essentially talking to people in a way that allows people with dementia to have the time to understand and the time to be able to deal with what they're doing. Dementia care mapping, a way of looking at, really, no matter what you do, using non-drug treatments, it works, it decreases agitation. So there's plenty we can do. But what we do, or what is done very commonly, is to jump immediately to pharmacotherapy. And this is my quick review of a substantial literature out there. So donepezil, memantine, anti-dementia drugs, they do not work for agitation and dementia. They do not work for neuropsychiatric symptoms. Anticonvulsants, sodium valproate, carbamazepine, they do not work. There's the odd little trial that from odd little places have shown odd little things, but taken as a whole, they do not work. Benzodiazepines, they do calm people down, but there are no trials because they cause falls and they have all of the problems that are out there. There was a positive sign in the citalopram, for citalopram, an SSRI, an antidepressant, that it worked a bit, but only those with least agitation and least cognitive impairment. So the people with least problems it worked for, but it also caused adverse cardiac and cognitive effects, which mean that limits the use of it. Antidepressants, no evidence of effectiveness except for citalopram, but widespread movement from treatment with antipsychotics to antidepressants. And why is that? Well, antipsychotics, they do work a bit, but we've known from the beginning of this century that there are problems that are specific to dementia. And those problems are increased mortality and increased serious adverse events that are caused by the antipsychotics and that occur at a higher rate in people with dementia than those without dementia. So the only licensed drugs for agitation and dementia are antipsychotics, but actually the licenses that we have are tremendously prescriptive, stating that they should only be used in persistent agitation, only for up to 6 weeks, and only in Alzheimer's dementia. As part of the National Dementia Strategy, I was asked to look at this and to carry out a ministerial review on the use of these drugs, and we quantified that about 10, 15 years ago, about 1,800 deaths per year were specifically being caused in people with dementia by the use of antipsychotics for the treatment of neuropsychiatric symptoms. And we then worked hard with primary care and secondary care to drive down the level of those prescriptions, and we did really well we've done really well, and the UK has had halved the rate of those prescriptions. And obviously we know that since the pandemic has come in, there's been tremendous problems for people with dementia, and one of those problems has been the rising use of antipsychotics, essentially using a simple response which has considerable risk attached to it to deal with the complex problem of agitation and the change in service provision that's happened during the pandemic. So I now want to just share with you some data from SINBAD. SINBAD is a study that was published in The Lancet at the end of last year, a large multi-centre randomised controlled trial in 26 centres in the UK, as I said, led from Sussex, led from BSMS, and again with tremendous gratitude to the people in Sussex and in Sussex Partnership Trust for all the hard work that enabled us to carry out this trial. So why mirtazapine? Well, the reality is that it's a very, very commonly used antidepressant in older people, and probably it is often used as a substitute for using an antipsychotic. So the message about antipsychotics have got through nationally and internationally, and so people are then presented with the question, well, what do? They think that the non-drug treatments are difficult and complicated, so they wonder if there's another drug they can substitute in, and that drug is commonly mirtazapine. So we carried out a trial to find out whether it worked or not. And this is a large and complicated slide with which I only want to make one point, that we started off basically comparing two drugs with placebo, mirtazapine and carbamazepine. Due to the fact that it's quite difficult to recruit people, we dropped the carbamazepine arm. So I'm just going to be presenting you data on mirtazapine versus placebo. The dose of mirtazapine that was titrated to was 45 milligrams a day. There were assessments at 6 weeks. The primary outcome is at 12 weeks. And we also carried out some longer term outcome data on that. And they were randomized 1-to-1. We were successful in doing this. The trial randomized 102 people to mirtazapine and 102 people to placebo. And I want to share, and we measured a whole lot of things, including agitation using the Cohen-Mansfield agitation inventory as our main primary. and measures of quality of life, measures of neuropsychiatric symptoms, measures of carer burden. And this is the answer. This is basically £2.4 million of the NIHR's money and the results of the trial. And what it shows is that the red line is mirtazapine, the blue line is placebo, and they are exactly the same. There is no benefit whatsoever over placebo in prescribing mirtazapine for the treatment of anxiety compared with prescribing placebo. And in fact, the placebo, this is not a placebo response that we're seeing here. What we're seeing is that people get better over a 6-week period, and they stay better no matter what you give them. Now, that's not everybody, but that's what it is on average. I think what we're seeing here is the effect of normal treatment and care, of problem solving within secondary mental health services, of all the things that we do, that is what decreases agitation in individuals, the non-drug treatments that we provide rather than the drug treatments. I'm not suggesting you look at that, but if you were to, you would find nothing in there at 12 weeks or 6 weeks in the secondary outcomes that suggests that we're missing anything. This is not because of the dose of drug we reach. This is not because of the types of dementia. It is not because of exclusion criteria or lack of data. It's because the drugs don't work. And it's the same for carer outcomes. What we did find is that there were 7 deaths in the mirtazapine group by week 16 compared to 1 death at the placebo group. Now, that's not statistically significant, but it's pretty concerning. And the level of adverse events was obviously higher in the drug group than in the placebo group. At 12 months, the mortality had equalized over time. So a conclusion, mirtazapine doesn't work for agitation in dementia. That's what we can conclude. It is not because of other stuff. It's because the drug doesn't work. No matter what it feels like in clinical practice, the drug doesn't work. But actually, if you don't give people drugs, then many of those will recover during that time. And this is a quote from Herbert Mencken. For every complex problems, there is an answer that is clear, simple, and wrong. And the clear, simple, and wrong answer for agitation and dementia is to prescribe a medicine, any medicine. It's so important that we treat it as a complex problem and actually find out what's going on, find out what the cause is, and deploy complex treatments such as non-drug care, like the person-centered care, like good communication, like other things that support carers to care. So a summary, agitation and dementia is a complex phenomenon. So it demands a complex approach to its management. Any conception of healthcare or medicine that says that there are simple answers to complex problems is essentially wrong, and that individual is trying to sell you that simple answer. That it is caused by dementia should be a last assumption, not a first assumption. Just because someone has dementia, it doesn't mean they don't get constipated or in pain. In fact, because of their dementia, they may express those and have those problems more. Pharmacotherapy should be a last line treatment, not a first line treatment. Now, I was very careful in my report in the ministerial report that I did, not to rule out drug treatments. Obviously, that is needed at times when risk is high, at times when there is a critical situation. But you need to make that a last line treatment, not a first line treatment. Data from this study support active monitoring of agitation without prescription, and that's the same as we recommend for depression. I think that psychotropic drugs should only be used when there is risk and other strategies have been unsuccessful or patients are very distressed. And many of the drugs that we use really aren't treating. So who aren't going to work? So who are we treating? Are we treating ourselves in terms of wanting to give people something? Are we treating the carers, be they in a nursing home or in other homes, rather than treating the patient? So who are we treating? So thank you very much for your time. It's been a pleasure talking to you, and I really wish you well with the rest of the conference. It's brilliant that you have so many people there. Could never have fitted all of those into the Sussex Education Centre or whatever. So it's brilliant to see the Centre of Dementia Studies doing so very well. And I'm I continue to be delighted that the vast majority of my research is carried out within the Centre for Dementia Studies. So thank you very much all.